update on pathology of the axilla.
Thank you. I'm sorry for not having been there at the beginning because I thought it was a previous session, so I was a little disappointed not to be able to give my talk.
Not at all.
Okay, so the sentinel lymph node and the pathologist point of view. It's a very long story, but we have worked a lot with the surgeons, and I will go through those different points during my talk. Before sentinel lymph node, you were performing axillary dissection for all the patients. We were taking sometimes only the largest lymph node. I talk about that more than 30, 40 years ago, or only doing one slice per node. And then we had the sentinel lymph node, so we started to do comprehensive analysis of sentinel lymph nodes with full inclusion, Bill valve dissection protocol, serial cuts, and immunohistochemical examination. And we have been able to find very small metastases as those metastases, for instance, micrometastases. For the rest of the axillary dissection, we were not doing such an extensive examination. So if we had a metastatic lymph node, only one slice. And for the normal one, we were cutting them in 2 or 3 parts and including them. But no immunohistochemistry unless we were having lobular carcinoma, because lobular carcinoma, sometimes they have very small inclusion, they look like plasmocytes, so sometimes we have surprise when we do immunohistochemistry. So I recommend to be very careful with lobular carcinoma, and also to be very careful for post-neoadjuvant cases. So starting working with sentinel lymph node, and we started in the 90s, it has led to a change in the TNM classification of node metastasis. So with the introduction of micrometastasis, so this is really our job as pathologists, looking at metastasis between 0.2 millimeters and 2 millimeters in size. And we also found very small metastasis, so some small cluster of cells. And this is defined as PN0 with isolated tumor cells. And we have different classification, and we added in the pathology report, for instance, PN0Y+, when we have found them with immunohistochemistry. During the 90s and beginning of 2000, we used also molecular techniques. We have completely dropped them now, but we had also a possibility in the TNM to say PN0 mol plus, when we found the metastasis by using molecular biology. And for instance, if it's a positive lymph node, we will say PN0 E plus if it's a nanometastasis, and SN for sentinel lymph node. So this is what we see at the microscope for micrometastasis. And for those very small clusters, as you can see here, that we only see because we do immunohistochemistry, so isolated tumor cells. Here we have a group of around 10 to 15 positive cells. If we have that post-neoadjuvant treatment, it's no longer PCR. It's very important to stress your attention that we need to be very, very careful to evaluate the sentinel lymph node post-neoadjuvant treatment, because if we find even very small cluster of cells, they are no longer considered as in PCR. So if it's an HER2 positive patient or a triple negative patient, it will change the adjuvant therapy. When we talked a lot during this session about de-escalation, but you have to know that before this stage, in pathology, we worked a lot on ultra-stratification. That means that the classic protocol from 2000 to 2010 was to do frozen section of the sentinel lymph node. And if it was negative, we were doing standard evaluation by H&E staining and immunohistochemistry. So at least 6 sections of the sentinel lymph node were examined by the pathologist. And we could find things like that either on slides or on cytology that we were doing during the frozen section. You can see here that we can see on cytology, we just put the glass slide on the node, and we can see that we have metastasis. Because of BP Vialet, at the end of the 90s, in my lab, I was in Marseille at this time, we applied his protocol. So during surgery, we were doing a very extensive assessment of the node that took sometime 1 hour. So the patient was in the OR, and the surgeon was going to another room to operate another patient. We were doing up to 60 levels of frozen section and immunohistochemistry. Happily, this has been dropped, but it was a lot of time. And we were also doing more than 6 levels, but also up to 60 levels of slides at the definitive histology. So ultra stratification of the sentinel lymph node. Because at this moment, we were thinking that maybe if we find at least some positive cells, it could change the prognostic of the patient. We know now, and it has been discussed previously, that the biology of the tumor is very important. And this will have an implication for the future, and I will go that in the next slide, whether it's a luminal tumor and a luminal A, or whether it's an HER2 or triple negative tumor. So at one point in pathology, we were just looking to hundreds of cells for one patient. It was extremely expensive, and happily we stopped that, and now we have a more pragmatic point of view and practice for the sentinel lymph node examination. So as I said, we had also a moment for 5 to 6 years where we were doing during surgery molecular testing. It was adding also half an hour to 40 minutes. So the patient in VOR, people waiting for our result to see if we had micrometastasis, but we were not able to see whether it was micrometastasis or small cells, because it was molecular biology, so we don't have an idea of the level of the invasion. So this is also finished. So where do we stand today? Today, we have stopped doing intraoperative assessment. So we don't do frozen section on the lymph nodes, sentinel lymph node during surgery, except for post-neoadjuvant. Because for post-neoadjuvant, this can change the way, because you can do axillary lymph node dissection if we find a positive sentinel lymph node. So this is the only indication that we have now for frozen section. It's post-neoadjuvant. But we don't no longer do frozen section. Of course, we look at the sentinel lymph node. If we find a macrometastasis, we will confirm it, and you will decide during surgery, do you go to axillary dissection or not? And we will see that we have a discussion if the patient is clinically node 0. We don't do any longer molecular screening. At final analysis, there is no clear international guidelines. In some institutions, they only do one section of the sentinel lymph node, and they look without immunohistochemistry if they see metastasis. We can see micrometastasis, we cannot see nanometastasis. It's impossible, but in fact, who cares now for 10 positive cells in a node? I think nobody, except after neoadjuvant. So really, after neoadjuvant, we have not de-escalated the pathological examination, but for the other cases, yes. What we do in my institution, we do 3 levels, and if we have any doubt, we do immunohistochemistry, but it's not systematic, and we only do that if we have lobular carcinoma. So this is to summary, no frozen section, except for suspicion of macrometastasis, and of course in the case of neoadjuvant therapy, and 3 level of H&E. If negative, immunohistochemistry is optional. How many sentinel lymph nodes? Probably you have already discussed that. What say the guidelines? It's better to have more than 1 sentinel lymph node, because we know that the false negative rate is less than 10% if you have 2. But if you remove more than 5, you will increase the morbidity. So what is recommended now is to have from 2 to no more than 5 sentinel lymph nodes. And that's also okay for us, because if we receive like 7 or 8 sentinel lymph nodes, it's a mini axillary dissection. For patients for DCIS, what do the guidelines say? No sentinel lymph node biopsy in DCIS patients, but we may do sentinel lymph node biopsy in some cases. In what type of cases? If the risk of upgrade to invasive cancer is high. If we have a large Comedo DCIS, high-grade, mass-forming DCIS, the risk to upgrade to an invasive carcinoma at surgery is between 7 and 11%. So in those cases, that's what we do in my institution, the surgeon will perform a sentinel lymph node biopsy, 1 or 2 or more if they want. And also, we will perform sentinel lymph node biopsy if oncoplastic breast conservative surgery is planned for the sentinel lymph node biopsy, because there is no data on the accuracy of the sentinel lymph node biopsy after oncogenic procedure. So these are the 2 exceptions where we can perform sentinel lymph node biopsy for DCIS. So what are the ESMO guidelines? Well, I think they were published at the beginning of 2024, along with the ESMO clinical practice guidelines for early breast cancer. And I think that they are very informative, because they really see, are you in the situation for primary surgery, or are you in the situation of neoadjuvant therapy? And according to that, you have different options for sentinel lymph node biopsy in the adjuvant or in the neoadjuvant setting. I'm going to detail some of the situation in the next slides. So if we have patients without clinical lymph node involvement, I think that today, it's ESOMA, ESMO guidelines, I think everyone agrees on that. Sentinel lymph node biopsy is the standard of care to assess the axilla lymph node status in clinically node-negative patients. And upfront axillary lymph node dissection for CN0 should be considered only for cases in which the sentinel lymph node has not been validated, such as an inflammatory carcinoma. So it's really a discussion for inflammatory or for locally advanced breast cancer with inflammatory presentation. In the other case, we are safe to perform sentinel lymph node biopsy. But now, surgeons, you are working a lot, and we are afraid as pathologists, because our job depends on what you do and what you send us to. Yes, so we are very dependent on you. There is a lot of work on surgical de-escalation, and I think you already had discussion on that. How safe and how far are we going to go into de-escalation? We have to be careful not to de-escalate too much. So today, no axillary dissection in CN0 patient, so clinical node 0 patient, in upfront surgery, breast cancer, if we have 2 or less than 2 positive sentinel lymph node. So now we have level of evidence 1 from ACOSOG Z0011 trial and AMOROS trial. They have shown that in selected patients for early breast cancer, it's safe to not to go to axillary lymph node dissection, even if you have to macrometastasis. Of course, as long as tangential wood breast irradiation is planned and adjuvant systemic therapy is administered. So, of course, you have to be careful that the rest of the treatment of the patient is not de-escalated, and here surgery, radiation therapy will be very important. We had discussion previously about the INSEMA trial that was presented at San Antonio. I think it could be really practice-changing, but don't forget two things. It's upfront surgery, and it's valid only for menopausal patients with small tumor, so maximum CT1, grade 2 and grade 1 tumors, hormone receptor positive, HER2 negative patients. So in this population, no sentinel lymph node, no axillary gesture at all could be possible. But we'll see in the future if it's safe, and you have to be sure that your patient will be compliant with hormonal treatment or CD4/6 inhibitors after that. In the neoadjuvant setting, there is right now a lot of discussion about de-escalation. So sentinel lymph node biopsy after neoadjuvant systemic therapy if the patient is CN0. So as we said in the previous session, as I said before, we really need to be extremely careful in terms of pathology. We need to really be very cautious and to do immunohistochemistry, because the precise definition of the YPN, so post-neoadjuvant evaluation by the pathologist, is fundamental for evaluating PCR and also for discussing subsequent therapeutic options. So today, even if we have a YPN0 I+, so very small cluster of metastatic cell in a node post-neoadjuvant, it's not PCR. So if it's an HER2 positive patient, it's TDM1 treatment. No longer indication of sentinel lymph node biopsy before neoadjuvant therapy. For the patients who are CN0 at presentation, undergo neoadjuvant systemic therapy, they can be staged with sentinel lymph node biopsy after neoadjuvant treatment if they remain clinically CN0. We have several meta-analyses that showed a false negative rate of approximately 7%. That is comparable that we have if we have an upfront detection of the sentinel lymph node. And we really need to have a meticulous pathology evaluation for the detection of neoadjuvant systemic therapy resistant axillary disease. The next step, the results are pending from trial and registry study, investigating omission of sentinel lymph node biopsy for CN0 only for triple negative and HER2 positive patient with PCR in the breast. But we have to be very cautious, but maybe for those patients, it will be in the future no axillary gesture at all. We'll see that in the future. If we have a sentinel lymph node biopsy for a patient that was CN1 before neoadjuvant, and the patient had a conversion to YCN0 after, is it possible to avoid axillary staging in those patients with axillary disease prior to neoadjuvant treatment who achieved a complete clinical and radiological response? Today we have a level of evidence 2, so we may avoid axillary lymph node dissection in selected cases. And this was very deeply discussed in St. Gallen, but 2 years ago, and we are still waiting for the trials. But if we have a patient with more than 3 sentinel lymph nodes that were taken, that those including the targeted axillary dissection, if it's YPN0, no axillary lymph node dissection, and surveillance. And of course, it's very important to inform the patient, but the axillary recurrence rate is very, very low, but we don't know the data on long-term survival. So before, making that dogma, we need to wait for the more information. So in conclusion, sentinel lymph node biopsy is really a quantum leap in therapeutic de-escalation in oncology. It's a model for de-escalation controlled by clinical research based on surgeon skills, pathologic assessment, and evidence-based medicine, with patient benefits and risk assessed, and it really assumes a dynamic surgical oncology research. And I think it's very, very important, all the work you do as surgeons to think about what to do with this sentinel lymph node. So in breast cancer, we have now the luxury to completely de-escalate even the sentinel lymph node biopsy in selected indication to avoid any armpit surgery. And just in conclusion, one slide. We had a discussion about artificial intelligence. Now we have the help of some algorithm to find, without any immunohistochemistry or molecular biology, the foci of micrometastasis in the sentinel lymph node.
Just depending on morphology.
Yes, just on morphology, with the machine really looking at specific clusters. And maybe this is something we could do during surgery. So it could help us a lot.
And the AI, just the AI.
With artificial intelligence.
Okay. Gross on morphology only. This is artificial intelligence.
Yes, by AI only.
Yeah. Okay, thank you.
Oh, thank you for your nice presentation. If there is any questions,
Professor Ahmed.
for Dr. Ahmed.
Thank you. Your lecture regarding the assessment of sentinel node intraoperative. Actually, you mentioned you don't assess intraoperative sentinel lymph nodes, but our policy you must assess. So in our country, frozen section or frozen machine is not available in all hospitals. Many of our pathologists depend upon toluidine blue staining and refracted light for thick films or imprint cytology. So what's your comment on these techniques?
What I prefer, if I have to do a frozen section, is to do imprints, because I'm not destroying the architecture of a lymph node. Because when we do frozen section on the nodes, the tissue after that is not as good. The immunohistochemistry cannot be as good, and we lose a lot of tissue because we do thicker sections. The imprint, something we use in hematology, we don't spoil the at all. It's very fast. And as I showed you, if we have metastases, we can see clusters of tumors. So for me, imprint cytology is the best.
But do you actually do the imprint on one single cut, or do you go through sections through the lymph
So
nodes?
what we do, if we have a big node, we do like 3 slices, and we do three imprints.
Okay.
To have a different level into the node. But I think it's the best. In my hospital, we have the frozen section machine. We have 2 of them, but we prefer doing imprints for the sentinel, because we do a lot of sentinel in gynae also, and for us it's the best, and it's better after for the evaluation of the sentinel lymph node.
This is before neoadjuvant or after neoadjuvant?
After neoadjuvant, it's different, because after
Yes.
yeah. After neoadjuvant, I will do both. I will do imprints, but if my node is very fibrous, because if it was a positive lymph node with a response, usually it's fibrotic. So it's easier to cut, so my technician will do very thin slides, and I will do a frozen section too. It's very good that you pointed that after neoadjuvant, because as I said, after neoadjuvant, it's really much more important, and we really need to do what we did before. I'm happy that the experimentation of Beppe Viale with the immunohistochemistry, I was a resident at this time. We were spending hours doing immunohistochemistry, and in VOR they were waiting for us with like 3 patients waiting for our results.
For 60 sections.
Yes, it was a nightmare, but I think that doing imprints plus frozen sections post-neoadjuvant is a good way to do. For the other one, in my hospital, they don't want any longer frozen sections. They have stopped. But sometimes, you know, when we see the node is big, we say, we do an intraoperative consultation for this case, because we have, the node is big, we want to be sure that we don't, you know, have a lot of metastasis, so we will do some imprints.
Thank you.
Okay.
Thank you.
Thank you so much, and now we will close the session. Thank you.